What's that stand for? Yeah, I kind of heard the correct answer. All right. Okay. So the definition, and you know, some people get diseases, don't read the definition. I don't know why, but progressive degeneration of the motor neurons, spinal cord, brainstem, and cerebral cortex. As you can imagine, degeneration in those areas is going to devastate the body and eventually lead to death. It causes weakness, muscular atrophy, cortical spinal tract signs in various combinations. The disease usually attacks mostly males. There's a higher male to female ratio, and in midlife, and typically they die in 2 to 5 years. Okay, so we're going to talk about subtypes of the motor diseases, and these are kind of combinations thereof. We're going to talk about each one in a second. PVB is a disease that attacks the nerve supplying the bulbar muscles. These disorders are characterized by degeneration of the motor neurons in the cerebral cortex, spinal cord, brainstem, and pyramidal tracts. This specifically involves basopharyngeal nerve, which is cranial nerve. Basopharyngeal, which one? 9. That's right. Vagus, 10. And the hypoglossal nerve, 12. Okay. PLS affects the voluntary muscles. UNN disease occurs after age 50, and they live for a longer time usually. All right, let's go on. Who's that guy?
Lou Gehrig.
Lou Gehrig, that's right. None of you are old enough to remember Lou Gehrig, nor am I, but they named the disease after him. It occurs in 1 to 3 per 100,000, so it's not that uncommon a disease. Male to female ratio is 1.5 to 1, although I've never met a female with ALS, so that's a statistic in the book. In my own experience, I've never met a female with ALS. Age of onset is 50s and 60s, occurs randomly throughout the world, so there's no concentration. Yeah?
They said that he had multiple head injuries when he played. You know, they didn't have batting helmets back then. Is there any
Yeah.
correlation to he got picked in the head a bunch of times and
Yeah.
in the second got hit? Is there any correlation?
Yeah, I agree. He may not have had ALS at all, and that a kick in the head. I mean, that's very strange. But yeah, they didn't know about multiple trauma to the head. That's a very new thing, actually. Mostly they talk about football players, but yeah, he got beat quite a bit. Baseball was not as safe as it is now. They don't have. I don't even know. I don't think they wear batting helmets. So I think batting helmets didn't come about until like the 70s. And boy, a fastball still goes 90 miles an hour. Yeah.
With ALS, I know a female, she's like in her 20s and she has it. Is that like super rare since it
Yeah.
only starts in the 50s and 60s?
Yeah, I'd even be willing to bet it might be a misdiagnosis.
Really?
Yeah. Yeah, in that age group, you would almost expect she would be, she might have a number of other disorders that would affect that age group. Yes, ma'am. Now I'm using the math. Thank you, that I appreciate.
I'll leave it.
All right, so I can lose it, okay. With the fellow that I helped along, he was a boxer, a prize fighter. So they misdiagnosed him for a long time as being punch drunk, as having so many concussions to the head that was what was causing his symptoms. The problem is, with the onset of the disease, the symptoms are weakness, cramping, atrophy, and fasciculations, combined with spasticity. How many diseases have those as characteristics? A lot. So this is not an easy diagnosis to make prior to what invention? What invention makes this a piece of cake to diagnose? An MRI. Yeah. I'll show you some MRIs. But after the advent of the MRI, it was like, oh, it can't be anything else. That's still not quite true, but yeah, an MRI makes it easier. They have grist DTRs. Now, I'll bet a lot of you have grist DTRs. That probably means nothing. A positive Babinski is a little rare. What's a positive Babinski look like? What do those do? They go up? Yeah. All right. It's distal limb to proximal limb to trunk to cranial nerve. Okay, that's also an odd progression. Usually it's central to peripheral. This disease is peripheral to central. Okay. Sensory system and sphincters are not affected. So they can feel everything and they can control their sphincters. 3-year survival rate is 50%. 6 years is 10. 10-year is 6%. So not too many people live very long with this disease. Having had a patient with it, I would say that might even be a blessing. It's a pretty horrible disease. Okay. Oh, no. Sorry. Somebody who doesn't know I'm in lecture. You can get, now, what else does lower extremity to upper extremity that you guys are familiar with? Because that's a very rare progression, lower extremity to upper extremity. So what disease do you guys already know of that does that? An acute disease.
Oh,
Guillain-Barré. That's right. Guillain-Barré is the only other ascending paralysis that I know of. So an ascending pattern with this would be very, very rare. It causes something called frontal lobe dementia, which is, I'm going to kill this phone, is degeneration of the frontal and anterior temporal lobes. What are those lobes responsible for? What's the frontal lobe responsible for? Personality, right? Temporal lobes, behavioral disturbances, language disturbances. So there's a pseudobulbar effect, which means it looks like what disease? Pseudobulbar? I lectured you on that topic. Parkinson's. Okay, you all get it now. All right. Uncontrollable bouts of laughter or crying without the emotions to go with it. Start laughing for no reason. All right. Male to female ratio is 4-to-1 in PMA. There's more systemic weakness. It's kind of like, how do I put it? One of the things is you'll notice people with PMA have no handshake. When you shake their hand, they just kind of, they have a lot of problems with that. It only affects the LMN and has a slower evolution than ALS, so that means they get to suffer longer. Okay, symptoms of PMA, again, muscle weakness, atrophy, fasciculation. By the way, the thing says fasciculations. That's not a word. The multiple of fasciculation is fasciculation. The multiple of deer is not deers, it's deer. So it's all over the slides. I fixed the ones I can find. It's a diagnosis of exclusion. What does that mean? Somebody raise their hand and tell me what a diagnosis of exclusion.
Rolled everything else out.
That's right. You can't make the diagnosis directly. There's no test for it. There's no way to do it except to say, oh, you know, this is probably PMA, not regular ALS. There's hyperreflexivity, which they all have, spasticity they all have, Babinski sign they all have, and cognitive changes they all have. 5-year survival is only 33%. 10-year survival is 12%. So they die quicker, but some live long. The primary effects of the corticospinal tract. You guys were studying it before when I came in. most signs develop, signs of ALS develop within less than a year. It's a quick, from diagnosis to actual full-blown syndrome is very short. 20% exhibit a slowly progressive course. Onset is usually after age 50, so they're practically dead anyway, right? Good, nobody shook their head, yes, that's good. Because if that's the case, God, you know, you gotta put me on an ice floe. Okay, no sensory involvement, marked spasticity with little weakness, different from PMA. No weakness, good handshake, all right? 50% develop urinary irritant symptoms. So a lot of frequency, a lot of urgency. That little tract in the bladder gets oversensitive. Welcome. Good afternoon. It's okay. You'll just be responsible for everything. Stuff happens. I had a guy, I gave a final exam in this community college in Houston, HCC, and we got done lab early, so I sent him out for the to study for their final. He went to his car and fell asleep and showed up the final an hour late. And he says, "Can I have an extra hour?" I said, "No." Right fast. Okay, PDA. Weakness and atrophy of the muscles innervated by the lower brainstem nuclei. Dysarthria is prominent. Emotional incontinence. I like that. That's a good one. Emotional incontinence. That means you have no control over their emotions. 1 minute they're smiling, next minute they're screaming at you. Respiratory failure is also the usual cause of death. Death occurs due to usually aspiration pneumonia. And the prognosis is about 2 to 3 years. Is a real quick act. Lab features, EMG shows fasciculations. So anybody ever see an EMG or experience an EMG? You experienced one?
That's the one with the needle.
Yeah.
Yeah.
Yeah, if you've experienced one, you've never experienced two. Kind of an uncomfortable little study, but the fasciculations show up as movement on the electrical scale when there's no signals been sent. They can do muscular biopsy, not a very accurate way of doing it. CSF is normal, CPK is normal. Why would the CPK be abnormal? What would cause CPK to be abnormal? Right, muscle breakdown. That's what you guys should know. All right. MRI may show involvement of the corticospinal tracts. That's what I said. MRIs are useful, but they're not the be-all, end-all. So, you know, you'll hear some doctors get out of medical school and the first 3 letters out of their mouth is MRI. Everything gets an MRI. Okay, these are EMGs showing normal contraction, slight activity, and at rest. And these are what denervation looks like. So you get odd spikes, which of course causes odd contractions. Fasciculation looks like, to me, it looks kind of like AFib, you know, where it's a chaotic baseline. And maximal contractions are not as effective, so they're not able to contract muscles. Biopsy looks like this. There's more bundles. There's more fibers than bundles. Interesting. Okay. And there's the MRI. The image is not real. I mean, it's not as obvious as it looks on this picture. Usually the findings are very subtle. All right. Obviously, these white tracks here don't belong there. So, there you go. Okay, pathology. There's a loss of nerve cells in the anterior horn of the spinal cord and motor nuclei of the lower brainstem. gliosis, that means extra glial cells are formed in the brain, and microglial proliferation. Boy, I'm drink of water, that's a mouthful. All right, thin anterior roots and denervation atrophy of the muscle. Anybody ever seen that? You know what that looks like? Maybe more uncommon to you guys because the most common form of denervation atrophy that you see is in polio. And I had a swim coach who had polio, but it's pretty hard to find anybody in this day and age who suffered from polio. But that's what denervation atrophy looks like. His leg, one leg looked just like skin over bone, there was no muscle. And he walked on it stiffly like an artificial leg. And there's a fiber, that's an anterior spinal cord image showing the atrophy of the nerve roots. See how the nerve roots is kind of spindly? Actually, we should have a slide of what a normal one looks like, but you can see that looks like a sick nerve. All right, the differential diagnosis for this one is tough, and there's a lot of things that look a lot like it. You can have cervical spondylosis, which is caused by a couple of different diseases. You can have multiple sclerosis, which we'll talk about later. Peripheral muscular atrophy, that's Charcot-Marie tooth. I think you guys have studied before. Muscular dystrophy, we'll also talk about later. Myasthenia gravis, and lacunar disease, meaning lacunar infarcts. Remember that these patients are 60, 50, 60, 70. So they may have more than one. They may have lacunar infarcts. So you do your MRI, you find lacunar infarcts, and you go, oh, I've got it. Everybody knows what lacunar infarct is, right? No? Okay. When you look at the brain on MRI, you see little areas that are dead. All right? Those little areas that are dead show up white, and they're moon-shaped, so they're crescent-shaped, so they're called lacunar infarcts. They generally don't affect function because the nerves around them take over. If you get a lot of them, then you start to show dementia. But before that, you may act perfectly normal and be having TIAs. And you'll report TIAs to your doctor, but they won't find until they look at the MRI that, oh, oops, this guy's having little strokes. Okay. I didn't write any notes on this. Great. Go back one. Okay, it's going to go through some of the diseases. So this is talks about treatment. It talks about different types of drugs, anti-spastic drugs. But here's the one you guys should be interested in, right? PTOP. So that's where I should be sending my patients. I think ALS is to you guys. I'm going to want all your cards when you graduate, so I'll have all these PTs to send. You got to be careful. You got to take a look at respiratory assessment. Remember that once it gets truncal, they may lose the ability to move their diaphragm on one of both sides. Hemidiaphragmatic paralysis isn't so easy to diagnose sometimes. They just complain of shortness of breath. But physical diagnosis, you guys all learned some physical diagnosis. You know when you tap out the chest, the diaphragm is too high on one side or the other. Problem is if it's on the right, you don't know if it's because of an enlarged liver or because that hemidiaphragm is paralyzed. On an x-ray, it looks pretty impressive because the one diaphragm is way up high. On the left side, the heart's in the way, so it doesn't quite get up as high. But on the right side, nothing's in the way, and you have the curvature of the diaphragm come all the way up to the middle lobe. All right, and this is interesting, and I didn't make these slides, but essentially it says, you're going to die, so you better take care of things you need to take care of. End of life preparation. You don't have that long. Only have 2 or 3 years where they may be able to function and take care of those things. So once they get the diagnosis, they gotta start thinking about where they're gonna be buried, who's gonna have durable power of attorney for their medical care and things like that, because they may not be able to participate in their own care. MS. Okay. Now, multiple sclerosis, I've seen quite a few cases. A lot of times it's difficult to diagnose. We had a young lady in our town, a mother of 3 children, who went from walking, talking, normal person to wheelchair to dead within a couple of years. Not sure why she progressed so fast, but the whole town tried to take care of her kids. There we go. It's an autoimmune inflammatory disorder affecting the central nervous system, myelin. All right, so you become allergic to your own myelin. Now, most people theorize that this has to be preceded by some kind of viral infection. Because the immune system, what does a virus do? It gets inside the cell and changes the DNA. Well, if you do that, and your body then recognizes that as foreign, and the foreign material is myelin, you're going to attack your own myelin. Everybody knows what myelin is, right? Okay. It says 2 or more deficits separated by neuroanatomical space and time. So what that means exactly is, you come to the doctor because I got a twitch in my right eye. It goes, oh, it's nothing, it'll go away. And it does, it goes away. Then I got a tremor in my left hand. And then my big toe does the same thing. That's how it starts. So if you go to the doctor with complaints over time of different nerves being affected, none of which are related to each other, they should start thinking MS. Male to female 1 to 3. And you do see a lot of it in women. I also see clusters. So that's kind of funny because you'll see 3 or 4 people in a small town all come down with MS at the same time. That's more than coincidence. You got to wonder what's going on. I'm not sure whether the racial differential is really there. Mean age is young, about 30, but there's peak onset can be 20 to 40. That's why I'm saying you have someone with a CNS problem and they're in their 20s, could be MS. MS mimics everything else because it hits different nerve groups. You don't know which nerve groups. Okay. Diagnoses less than 10 years old or greater than 60 are uncommon. Worldwide distribution, total worldwide, 450,000 total worldwide. I'm sorry, U.S., 2.5 million total worldwide. Well, that's a lot of people. Prevalent northern climes. That's another good, that speaks toward viral illness again, because viral illness is more common in northern climes. So you start putting the puzzle together, it sounds viral. Someday we'll have effective antivirals against a lot of different diseases, and maybe we can actually treat and cure these people. That'd be nice. All right. It's based on typical clinical features, which are disparate nerve ending problems, different nerve roots. All right. It's true of a lot of things we do. Group vesicles on a erythematous base of a single nerve ending is what? You have a rash that's group vesicles on an erythematous base.
Shingles?
It's along the shingles. All right. But what if it occurs along 2 roots? Is that still shingles? Probably not. So you got to take a look at the clinical features first and say, okay, this sounds like, in real diagnosis in the real world, you have to have a suspicion for something first. For instance, 2 weeks ago, I had a patient come into the hospital I'm working at, which is an alcohol and detox center. And she comes to me the next morning and says she has the worst headache of my life. I said, oh really? So I laid her down on a stretcher and did a Kerning sign, and guess what she had? She had meningitis. And when I told the head nurse she had meningitis, she looked at me like I had two heads. Oh, come on, she doesn't have meningitis. I said, this is meningitis. It turned out she had aseptic meningitis, but she had meningitis. And she goes, how did you get that? Because she said, this is the worst headache of my life. That's one of the signs of meningitis. When you get that statement, without asking for it, you just get that statement, you better think meningitis. Okay, there's slow conduction velocities on evoked potentials. Of course, you have to know to ask for an evoked potential. And you're not going to do that if you don't already have a clinical suspicion. And white matter lesions show up on MRI. All right, and oftentimes I want to tell you, these musculoskeletal diseases or central nervous system diseases are often picked up by the PT because you guys are working with them physically. So the doctor who's spending 5 minutes with them may not pick it up. You're spending an hour or two with them, you might pick it up. And you have to not be afraid to tell the doctor, hey, you know, this looks a little like MS. You want to take a look at that. Okay, and the last thing you're going to do is a lumbar puncture. Whether you're a practitioner or a PT or anybody, you don't just rush off to get a lumbar puncture on somebody. They won't thank you for it, especially if you're wrong. Okay, so this is talking about the topography and microscopy of the brain. Topography meaning CT or MRI. The periventricular spaces, the spaces in the brain where the veins, I'm sorry, the perivenular spaces, are the spaces in the brain where the veins pass through. Just like in bone, you see these little nicks in the bone, they're not fractures, they're where the veins are coming in the bone. Same thing happens in the brain. There are spaces where the veins have to come through, otherwise how would the brain drain? In MS, you see a widening of these spaces. Again, you understand we're talking about qualitative versus quantitative. We don't measure the perivenular spaces. Some neurologist looks at it and goes, those look wide. You probably go, what are you even pointing to? So I'm not sure that some of what we teach you here will ever be used in clinical practice. It's nice to know, and you can really wow a radiologist if you go, well, are the perivenular spaces wide? You go, PT has me that? So, just a little point, write it down, get a brownie point somewhere. Macrophages are involved in the devitalization. Why? Why would a macrophage be involved? What's the deal with the macrophages? Right, it's cleaning up the debris. So you're going to see macrophages, and of course they stain. All right, monocytes can turn into macrophages. So you see monocytes, and they're involved in the inflammatory process. It looks for all the world. There's the CT. See them? See the little white spaces? Okay. But more, I think the stain, oh, they didn't show the stain. Okay, I don't have the stain. For those of you that are microscopists, there's a prominence of nuclei because of the monocytes. It looks like an inflammatory process. So you have PMNs, you have monocytes, you have macrophages of all types. It looks for all the world like inflammation. All right. So we have the prominent perivenular spaces that you can see by the arrows. This is a 43-year-old male with MS. There's attenuation of the image. I don't know if you have to know that much, but MRs have various strength proton images, and I don't even know what they mean. This is a TRTE 7900 and /17, whatever that is. Shows widening of the perivenular spaces as a string-like hyperintensity arrow show. This one's one on and these are on lateral. Awesome. And I really don't know the difference between weighted image So everything I know about MRIs and CTs I learned in the field, and no formal education in the area. Maybe I ought to take a course, I don't know. Okay, so these are kind of graphs over time of how benign multiple sclerosis takes place. So they're little peaks, little flares. So I keep saying she because when I know it's a she, but the patient will be fine for a while and then gradually get these little spikes, and you notice that that baseline is going, this baseline is going up, so it increases very gradually. And you have relapsing or remitting multiple sclerosis where they never come back to baseline. They just get a little worse each time. And then there's secondary progressive where they start off like this and then they just go right through the ceiling. And then there's primary progression where they just gradually get worse, steady increase in disability without attack. So those are various courses. All 4 courses can be seen in MS. So you can see why it's hard to make a diagnosis.
Is there any way to predict early on which one would happen, or only once it's happening?
Nope. And this one's going to fool you because you think you're looking at this and you're looking at this. What does, the one that's easiest to diagnose is this one because it pretty much they come back to baseline.
Can't see which one.
Oh, the arrow doesn't show?
No.
Oh, darn. Okay, the top one is the attacks occur, but then they come back to baseline. All right, so if you're coming back to baseline and it happens 3 or 4 times, you could probably say, okay, that's probably not going to progress. They're going to live a long time. They're not going to end up in a wheelchair in a couple of years, and they'll probably be okay except when they're having an attack. So you get them a nice pair of crutches or a walker, and you say, whenever you have an attack, use your walker. All right. The next type down, they never come back to baseline. They gradually get worse. So first I could walk unaided, then I need a cane the next time after an attack, then I need a walker, and it kind of progress, and then I need a wheelchair. So that, I'm just speaking of lower body motor, that's the way it progresses. The thing is that for all your efforts as PTs, there's probably not too much you can do for this. You might be able to bring them back to where they're coming back a little bit better than they would otherwise. But physical therapy doesn't have a lot to do with MS. It's very hard. The third one down looks like the other one. It looks like, you know, it's progressive. Or it might even be flat, and you're going, oh, you're going to have a long course. That's why you don't make any predictions. Because you can say, oh, well, you came back to baseline, you're probably going to be fine. Then the next attack, you don't quite make it to baseline. Then the attack after that, you make it to baseline again. But then it progresses very rapidly after that.
Is there any general time period for those, or timeline for how long those exacerbations
No,
occur?
it's very variable. It's usually a fairly long course, but it's not, you can't predict it. And if you get one that looks like the bottom one, you can't tell whether that's MS or ALS by symptoms. So you can actually have a patient with MS die early on, die in 5 years. It's a bell-shaped curve, so at the bottom of that curve is early demise. But remember, we're talking about, yeah, these are young women too. It's a little different than a 60-year-old guy who's a 30-year-old woman. Yeah.
With the benign, do you know like how long the attacks last, or does it always vary?
That varies also. The attack, they wake up one morning, they're fine the morning before, they wake up the next morning, you can't get out of bed.
And then they go back to fine.
Then they go back to being fine.
So it doesn't affect their lifespan like the others.
Yeah, it does.
Oh, it does.
It just nobody. It's harder to predict because they go back to normal. It seems like, oh, that was a mistake. That didn't really happen. And I can tell you, in patients that have that, it's very hard to convince them they have the diagnosis, even though you may have all the other signs and symptoms. They're not going to believe it because it comes back to normal. So, well, you know, I couldn't move my right arm yesterday, and now I can, so it must be better. It's tough. That's one of the hardest ones to get a patient to adjust to. If you know you have a terminal disease, you can adjust to that. But if you think you're getting better, then even if you're told you're not, you still have trouble adjusting to it. You know, you don't want to believe it happened. Okay. Clinical manifestations. Again, this is relapsing, remitting type of MS where they actually get better. Optic neuritis is a common one. They'll come to the doctor and say, I'm blind in one eye, what happened? Or maybe even go to the ophthalmologist. And then the next day they can see again. They're like, what was that all about? Well, that was attacking the optic nerve. Partial transverse myelitis is numbness, weakness in an extremity or bladder or bowel or sexual dysfunction that may last weeks, months, and then go away. It's all of a sudden it's bad. Or you've given them medication and they think it's the medication that made it better. Remember that if you're in primary care, you aren't going to necessarily run somebody off to do an MRI or EMGs or a brain biopsy. You know, if somebody comes to me and says, I can't see out of my right eye, I'm probably going to send them to an ophthalmologist or a retinologist, thinking maybe they have, a retinal prolapse or something's going on, they need to take a look at it. So you have to look at this in the broad sense of all diagnoses. The family practitioner may miss this for years. You guys have a better chance of picking it up because you're going to see a weakness, especially if you send them to a PT. You say, oh, they must have had a stroke or something, they have a weakness in their right arm. And you start working with it and all of a sudden they're 100% better. Well, if you're sharp guys from my class, then you're going to call the doctor and go, hey, I think this person has MS. And he's probably going to go, mind your own business, PT. But, in the real world, you have to present that a little gingerly to a doctor, but you may pick it up and they may not. You can have brainstem and cerebellar signs. Those are kind of interesting because they can have diplopia, double vision. Again, they're going to go to an ophthalmologist. They can have dysarthria, so I don't know where my arm is. I'm having trouble with that. Or ataxia. They get pulled over by the police and get thrown in the drunk tank and they're not drunk. That used to happen, now we have breathalyzers. See, that's what I get for working in alcohol and drug docs in that area now. And you can have cognitive or hemiparesis or hemisensory changes. And it's very hard to make this diagnosis. It may sound pretty cut and dry on paper, but believe me, it's not. Yeah, and it is truly a diagnosis of exclusion. And a lot of these people go through a ton of tests before you can actually say, hey, I think you have MS. Okay, the secondary progressive, the one I showed you was the third one down, has cognitive changes early on and gait impairment. That's what I was talking about, going from, okay, I need a cane and then I need a walker. He doesn't want to give up. He's a headhunter, wants me to take a job. Okay, and in the primary progressive, where it goes straight up, that one usually involves spinal cord and brain first, and then a lot of times you'll see bladder, bowel, and sexual dysfunction. To make it clear, sexual dysfunction means they can't have an orgasm. Because you'll hear that on they advertise certain SSRIs, they talk about sexual dysfunction. And a patient comes to you one day and say, what does that mean exactly? And that's what it means. All right. MRI and evoked potentials can be done. Evoked potentials show visual, brainstem auditory, and somatosensory deficits. CSF can show an increase in protein, glucose. Cells are usually normal. but there's an increase in protein. Why? Why is there an increase in protein in CSF? Anybody? Nobody? What's slime was made of? Not just protein. Protein, what else? Yeah, lipoprotein. So, fatty acids and protein would show up in the CSF. Okay, there's the presence of oligoclonal bands. I don't know what that means. And there's an increase in IgG synthesis. So if you do a immunology study, you're going to show high IgG. Why? Because they're allergic to their own myelin. So you're going to have high IgG rates. Okay, there's a healthy brain, and there's a brain with plaque size. All right? Plaques supposedly caused by MS. Do other diseases have plaques on the brain? Yeah, which one? Pardon me? Parkinson's, what else? The other lecture I gave you? Alzheimer's? Alzheimer's has plaques too. I'm glad you guys all remember that. Warms my heart. Okay, and there's a nice spinal MRI showing a plaque right there. Also, anybody else know what they're seeing on this MRI? Anybody see anything else? See the big plaque? Well, what else is on this MRI? Anybody notice anything different about this MRI? Yes! Good for you, that is. This is a herniated disc. So that little part of the disc shouldn't be there. So yes, that's a herniated disc. So this patient might have even come in complaining of back pain, and they said, oh, look at that, there's a plaque. And we did the MRI. Not a good thing to find. I hate to have a patient come back and go, I'm sorry, you have a terminal disease. But it happens.
Where at exactly?
Right here, this big white thing here. The big white thing like this. See the red arrow? It's pointing to the big white thing. That's plaque. And 2 vertebrae above that is a herniated disc. I think there's a way to make the pointer visible, but
This would kind of like I see it.
yeah, I'll see if I can do it. No. What has it? Oh, this?
Yeah.
Okay, let's see if I can not shoot myself in the eye. And that's not it. Oh! And it's a green laser too. Okay, so this is the plaque. And right there is a herniated disc. So, I told you I had to teach myself to read MRI, so you guys are lucky you can actually take a course in it. I guess I could now. Okay, and this is what the evoked potentials look like. So, unlike, you guys ever heard of what the definition of a double-blind study is? Do you know what a double-blind study is? No, when 2 orthopods are reading an EKG. All right. So that's me with evoked potentials, okay? It's like, okay, there are a bunch of squiggly lines, but you can kind of see that there are some normal and abnormal waves here. The latency period is overly long. And the P100 wave is different, but I don't know what a P100 wave is. Some of these slides are really interesting, but, you know, are you ever going to see a raw evoked potential readout? Probably not. What you're going to get is a report from the neurologist that says the evoked potentials show this. So at least you can say, oh yeah, I saw one of those ones. Okay, this is interesting. I know what this is. This is gel electrophoresis. Another thing you're never going to see. But I'm actually old enough that we learned to do gel electrophoresis in the lab. They taught us how to do it. So I know what these bands mean. And it's really interesting because this might be paper also. With paper electrophoresis, you dip the paper in your solution that you're testing and let it rise to the top of the paper and then spray it with a special stain that stains the protein and shows these kind of bands. Then you got to know how to read them. But what this shows is, in normal, you have kind of a normal distribution of IgG. We all have IgG because we're all allergic to something. We're all allergic to our environment in some way. So we have certain immunoglobulins that we have all the time. But in MS, there's a clumping of the IgG, which are called oligoclonal bands. And these bands become very bright bands on the electrophoresis to show that there's an acute reaction taking place to the patient's own body parts. Okay, that was an interesting slide change to that. Okay, prognosis is favorable with a lower relapse rate. I think I already told you this somewhere. So, if the relapses are spaced very far apart, you remember that slide, then they have a better prognosis. A younger age of onset, being female, initial symptoms of optic neuritis and sensory changes, and complete recovery after relapse. So it's the ones where the peaks come back down to baseline. Unfavorable is a high relapse rate, frequent attacks within the first 2 years of the illness, older age of onset, incomplete recovery, early cerebellar signs, and weakness on onset. The woman that I knew didn't fit any of these well because she was fairly young and female, so she should have a favorable prognosis. She just didn't. Yeah.
Is that saying the younger you get it, the more favorable you?
Yeah.
Okay.
Apparently, because of the younger age and the more physical vigor, you're able to resist the alert. Your body repairs itself better. And as you get older, that repair fails. I was explaining to one of my detox patients that he said, well, I don't understand if the liver can regenerate itself, how do you get cirrhosis? Well, if you keep regenerating, like anything else in the body, you do it over and over again too much, it makes a mistake, and the cells start getting perverted and don't look quite the same anymore. Same thing's true here. If you've got rapid relapsing going on, then the body does not have a chance to repair itself, starts making mistakes, and you start getting worse prognosis. Okay, do any of these work? Absolutely not. All right, this is a list of our futile effort to treat this. And I want to tell you that none of these items are very effective. A couple of them are now used for Alzheimer's because there's some idea that maybe the brain has the ability to repair certain areas, or you can direct neurochemicals to do certain things. I doubt that really works very well. Interferon B is like used for everything that has anything to do with the immune system. Any autoimmune disease, right away they use interferon B. It's been fairly successful against Hep C, but I don't know what else it actually has been successful against. So something to keep in mind, but for the most part, there isn't really any treatment. And this treatment works. This is the second one down, PTOD, does work, all right, and you can control the spasticity with muscle relaxants. I don't know about Valium, diazepam, but baclofen works pretty well. And anticholinergics work for the bladder, so you can use some ditrophan and stuff like that for the bladder to help with the spasticity. You got me on sexual dysfunction. I have no idea what those do. And the fatigue, you can use a couple. There are a couple. Amantadine seems to work, and amantadine is used to treat what? What is amantadine? What class of drug is amantadine? Pardon me, somebody speak up. Amantadine? No. No. It's used for viral infections, for AIDS. And, of course, cognitive therapy gets the behavioral people, the psychologists, the psychiatrists involved.
Yeah. Is this supposed to have a physiological effect on the virus? Or?
I don't know. If it works, you gotta wonder if there isn't some viral cause for this. Why does it work? How did they find out it works? Well, they said, let's try Manfred and see if it works. You know, it's like, if you read some of these studies, sometimes why they chose to run the study is because somebody had an idea, well, maybe that'll work, let's try it. So they do a clinical trial, and then they find out it works. And then they get the top scientists in our country, the FDA, to approve it. And then the FDA finds out 3 years later that it kills you and disapproves it. A la biopsy. All right, we're going to take a break. When we pick up, we're going to start on epilepsy.